Hello, and welcome to a presentation from the Kentucky Infection Prevention Training Center. This presentation is Infection Prevention and Control for Fire and EMS. I'm Kirsten Trudeau, and I'm one of the nurse practitioners here at the Training Center, and I'm thrilled to be presenting to you all today on this topic. Infection prevention and control are key to keeping fire and EMS professionals safe, but resources on this topic can be limited. So today we will discuss the basics of infection prevention, why it matters, and what to do to keep yourself and your patients safe when responding to calls. Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. I have no financial interests or other relationships with the manufacturers of the products, and no commercial support was provided for this educational activity. So today our objectives are as follows: to list the occupational risks and exposure rates among emergency medical services and fire colleagues, understand the role of a DICO officer and what they do for the agency, describe modes of transmission and way to prevent exposure for each mode, identify standard and transmission-based precautions for EMS scenarios, and select appropriate disinfection methods. So first of all, why does infection prevention and control matter to fire and EMS? Well, you all are on the front lines to the folks in the communities you serve, and encountering infectious disease when you care for a patient is likely a common occurrence. Basic infection prevention and control efforts can prevent the transmission of infectious diseases. It improves healthcare worker, EMS, fire, and patient safety. It's estimated that there are 1.5 million EMS and fire professionals in the U.S., with 794,300 police and 493,100 correctional officers. That's a lot of people that are placed on the front lines where these exposures can occur. So this table shows some data from the CDC on the number, sex, and age of injured EMS clinicians who were treated in U.S. emergency rooms, and almost 17,000 of these injuries occurred. Males made up a bit more than females at 59% versus 49 or 41%. The age group with the highest number of injuries was 25 to 34, and that group made up about 41% of those total injuries. So this is an interesting article on occupational exposures and injuries among EMS workers. And this was a descriptive surveillance study looking at data from a follow-back survey of EMS workers on the National Electronic Injury Surveillance System, or the NESWORK platform. And so the study respondents here were treated in the NESWORK sample hospitals from July of 2010 through June of 2014. And the respondents were over the age of 18. So the respondents were identified through NEAS, and then telephone interviews were completed on those who verbally consented. So looking at that analysis, the ED treatment for exposures to harmful substances occurred at a rate of 2.1 per 100 FTEs. And so most of these involved blood, respiratory secretions, and needle sticks. And needle sticks made up the majority at 21%, followed by oral secretions being spit. Now, whether that was that included whether it was an intentional or unintentional exposure to that, being 14% on that. And then not including needle sticks, the majority of injuries occurred through the arms and hands. So additionally, those exposures tended to occur while wearing gloves, but not protective gowns. And then eye injuries and exposures were also noted, as many occurred without eye protection worn. So think about the PPE that you wear during your patient care. Would you be protected if any of these injuries occurred to you? Looking at further data from the CDC, this is a breakdown from events causing EMS clinician injury in 2024. So I've highlighted the events where infection prevention and control practices may have been lacking. So harmful exposures accounted for 15%, and contact with objects and equipment at 12%. So additionally, the sources are broken down for the injury as well. So persons, plants, animals, and minerals made up 53%. And tools, instruments, and equipment made up 11%. So, wearing personal protective equipment when appropriate, as well as practicing safe injection practices, may prevent exposures and injuries. And we'll go through both of those infection prevention and control elements in this presentation. So this all kind of seems like a lot of information that we're going to go through, but you have someone as a resource. So who can help you with all of this and when you have problems or questions, and that's going to be your DICO officer. So DICO stands for Designated Infection Control Officer. They're a healthcare professional. They typically serve EMS or fire. They assist with exposures and they can act as a liaison with facilities receiving a source patient. So they really act as the agency's infection preventionist, much like a hospital has an infection preventionist. This is the person at the agency that specializes in stays current on infection prevention practices. So they must stay current on changing guidelines. They can conduct research, monitor and update policies and procedures as needed with changes in guidelines. So let's start with the basics of the chain of infection. All of these pieces of the chain must be present for an organism to survive and be transmitted. So first you need the microorganism, and then the reservoir or the source. Then you need a port of exit, a mode of transport, a port of entry, and then lastly, that susceptible host. So only one of the pieces of the chain has to be broken to stop the transmission of infection. So things like wearing personal protective equipment, performing hand hygiene, and cleaning and disinfection are all effective methods for breaking that chain. So let's talk modes of transmission. We'll focus on contact, droplet, and airborne. Additionally, some pathogens are transmitted via vectors like insects, and then some pathogens can live on inanimate objects called fomites, and they can transmit infection this way as well. We're really going to focus on the contact, droplet, and airborne for this presentation. So when you're thinking about modes of transmission, you want to be thinking about the precautions that would be appropriate for the symptoms the patient is having. And so this is a really nice algorithm from the ASPR Tracy EMS Infectious Disease Playbook. And it should be used really as a dispatch screening tool to suggest the highest level of precautions that may potentially be needed. And then the on-scene evaluation is then required, and it can be used to adjust the precautions as needed. So you can see here, person calls in for illness, you have this sick person, the dispatch person just starts to go through this algorithm. So is there any local infectious disease outbreak or epidemic screening questions that need to be asked? Is there concern for something going on in the community? If the answer is yes, and they have that specific exposure or symptoms, they're going to get that disease-specific precaution. Now, if the answer is no, then we move on to international travel or illness screening questions. So have they traveled anywhere to an area of concern? So anywhere that you might be concerned about, like Ebola virus disease or viral hemorrhagic fevers, anywhere with MERS, COVID-19 or novel influenza. If the answer is yes to either of those, then they're either going to get the Ebola virus disease and viral hemorrhagic fever precautions, which is kind of a whole other subset of precautions that I'll briefly touch on here in just a bit. And same with the other for MERS or novel influenza or COVID. These fall under the special respiratory precautions, and I'll touch on these as well. But if neither of those are a concern, travel history is not a concern, no other illness screening questions to be of concern, you move down to this no specific syndrome identified. Okay, so you get to their symptoms. Do they have cough or respiratory infection? Yes. Is there any concern for tuberculosis, chickenpox, measles exposure? If the answer is yes on this, they need to be put in airborne precautions. If the answer is no, but they still have that cough, then we need to put them in droplet precautions. If the answer is no to those respiratory symptoms altogether, we move to vomiting and diarrhea. they get contact precautions. If the answer is no and they're having other symptoms, say you're seeing them for, an injury of some sort, standard precautions is what will be applied. So, as you're considering what precautions are needed, let's take a look at the hierarchy of controls. So, at the core of infection prevention and control, you start at the hierarchy of control. And what I really want to point out here is how many layers we are into this process once you start talking about the use of PPE. So, there are many more effective control methods to prevent the spread of infection, but once the infection is there, you have to use PPE. So this is where those transmission-based precautions come in. But I do implore you, if you haven't already, take a look at what control measures are in place at your agency before transmission-based precautions and PPE are needed. All right, so standard precautions. Let's discuss standard precautions. So this is your first line of defense. So it's used for all patient care. It is based on a performed risk assessment, and its goal is to prevent the transmission of pathogens. Its goal is to prevent the transmission of pathogens to both the healthcare workers. This includes fire and EMS, as well as patient-to-patient spread. So these are the standard precaution core components. So these include hand hygiene, wearing personal protective equipment if exposure to infectious material is a possibility, practicing good respiratory hygiene and cough etiquette, proper handling, cleaning, and disinfection of medical equipment and the environment, textiles and laundries handled with care, safe injection practices. So the goal is to provide PPE as needed to prevent those possible exposures. So, standard precautions on arrival. If possible, initial assessment of the patient should be done with 6 feet between the provider and the patient. This provides that just a little extra layer of protection when you put some distance between you and the patient, if possible, to determine any additional personal protective equipment you might need. So you want to implement standard precautions and infection prevention measures as appropriate. So what PPE might you need? What activity is occurring? And remember that donning and doffing orders, so the order that you put PPE on and take it off, that matters because if you put it on incorrectly, you could be contaminating yourself. Or the PPE, same when you take it off. If you take it off incorrectly in the wrong order, you could be contaminating your person. So what then when you take the PPE off, what do you do with that discarded PPE? So considerations for the patient as well. If respiratory symptoms, if the patient has a cough, can they tolerate a surgical mask? That can be an additional thing that you add to protect yourself and others. If the patient can tolerate a surgical mask, have them wear it. And then hand hygiene is so important and absolutely essential to standard precautions. So, on that note, when do you perform hand hygiene? So, the World Health Organization recommends the 5 moments of hand hygiene to answer the question of when. So, they say before touching a patient, before a clean or aseptic procedure, after bodily fluid exposure risk, after touching a patient, and after touching patient surroundings. So, we've reached our first IP 911. So I've placed these throughout the presentation to highlight specific struggles and nuances relative to infection prevention practices in emergency services. And this one focuses on hand hygiene. So wearing the same gloves during the entire run, that can be an issue if you're not performing hand hygiene at the appropriate moments like we just discussed. So when do you perform hand hygiene? What about soap and water versus alcohol-based hand rub? So alcohol rub is actually the preferred method, but if you have visibly soiled hands, then soap and water is going to be what you would need to do. But we know that that's not always available when you're out on a run. So if it's not available at the time, we do the next best thing, which is using alcohol-based hand rub until you can get to a sink where you can use soap and water. So this study correlates nicely with that last IP 911 for hand hygiene, showing that compliance rates for hand hygiene and emergency services can be suboptimal. So all of the struggles and areas of opportunity we discussed today are not meant to say, hey, you're no good at this, but really just to point out the risks and provide a means to improve. So EMS and fire professionals, they face a host of nuances and challenges on the scene that make some infection prevention practices more difficult. But we can work together and to improve safety for you and the patient. So now this study from VK et al., it aimed to look at hand hygiene compliance, behaviors for glove wearing, as well as basic hand hygiene adherence with hair, nails, and jewelry and EMS professionals internationally. So this was a prospective observational study, and countries included were Finland, Sweden, Denmark, and Australia. So this study was conducted from December of 2016 to May of 2017. Now, this was a smaller study, but they still did 240 hours of observations, and that was done by 2 observers. So there were 77 EMS providers observed and 87 patient encounters. So with those encounters, there were 1,344 hand hygiene indications recorded, and the total compliance was 15% for hand hygiene. Now, the breakdown based on the World Health Organization moments was low. 3% before patient contact, 2% before clean or aseptic procedures, 8% after the risk of contact with bodily fluids, 29% after patient contact, and 38% after contact with patient surroundings. And glove use was noted in 54% of the indicated times. Now, new gloves before patient contact was 48% and only 14% in all clean or aseptic procedures. Continuous use of the same gloves, even after a hand hygiene indication, was noted 21% of the before patient contacts and 64% before clean or aseptic procedures. So the behaviors and rates varied among these various countries, but the rates overall and generally by country, each country showed much room for improvement. And additionally, you can tell by the moments, the breakdown of the World Health Organization moments, you can see that the EMS professionals naturally tended to comply with behaviors geared towards self-protection. So after patient contact, after contact with patient surroundings, those percentages were higher. They tended towards self-protection as opposed to patient protection. But we have to remember that this is a two-way street. We have to protect the patients just as much as we have to protect ourselves. So what do you think the rates look like in the United States or at your agency in particular? What about your practices specifically? So we use this visual to show the importance of performing hand hygiene prior to donning gloves. So we had healthcare workers work around an area with fluorescein powder on their hands. And then this is what the box looked like after we finished the simulation. So all the areas glowing are the contaminated areas. This shows how not performing hand hygiene can contaminate gloves in the box even before you put them on. So if you perform hand hygiene before you grab a pair of gloves, but the person before you didn't, they've already set you up for failure because they've already contaminated the gloves in the box. And you can see that with the glowing powder here. So here's our next IP 911. Gloves are not a substitute for hand hygiene, and here's why. So let's watch this video. So this is fluorescein powder, and she rubs this into her gloves, and so you can tell that this is kind of simulating your contaminated or used gloves. So after you've had contact with the patient, performed patient care, this would simulate your contaminated gloves. So you can see that she carefully removed her gloves, but under the light, you can see that she's still self-contaminated. And so you can see the areas glowing where she contaminated herself, even with careful removal of gloves. So this is why hand hygiene is so important after you remove your gloves. And it's also a good visual of gloves and why the moments for hand hygiene should be followed. All right, so you're on the scene now. How do you proceed and modify precautions as needed? So again, this is another great algorithm from the ASPR Tracy EMS Infectious Disease Playbook. So you're on the scene, you're looking at the signs and symptoms of the patient, you're kind of getting a history from them. So based on the different types of symptoms, you might have a host of different types of precautions that you should implement. So if they have GI symptoms, but they have a travel history, then you might need some very specific, Ebola viral hemorrhagic fever precautions, which again is something very specific that we will touch on. But more likely, what if they've had exposure to norovirus or they have a history of C. diff or know they have C. diff? Then they need to be in contact precautions. But if they have a fever or flu-like symptoms, then you can look at this algorithm to determine what precautions they might possibly need, particularly if they know they've been exposed to something. If they have a cough and they know that they have TB or they know they've been exposed to TB, then they need to be in airborne precautions. Um, Something a little bit more obvious is if they, if you're looking at their skin and they have any large open wounds with drainage, they need contact precautions. Um, if they have, zoster with open lesions, so shingles, then airborne and contact precautions if those lesions are open. Um, and then if they have prior antibiotic resistant infection, so if they have a multi-drug resistant organism history or an MDRO, that would be considered like MRSA, or vancomycin resistant enterococci or VRE. Those folks would be placed in contact precautions as well. So you can use this algorithm to kind of hone in on whether or not the dispatch screening tool was correct, if you need to add any more PPE, or if you possibly can take PPE away. All right, so always maintain standard precautions. Standard precautions, like we said, done on every patient. But transmission-based precautions are an extra layer of protection based on the suspected pathogen and the mode of transmission. So we'll talk about each type of transmission based on precautions. Um, excuse me, we'll talk about each of the different types of transmission-based precautions. So we'll cover contact, droplet, and airborne. But I do want to note that the ASPR Tracy EMS Infectious Disease Playbook, it does detail precautions and guidelines for special respiratory, Ebola virus disease, and viral hemorrhagic fevers precautions. I'm not going to go into those for this presentation because those are very specific, but definitely refer to that playbook for those special circumstances, because it outlines it very well. It's very detailed, and it will outline everything for your agency. Contact precautions. So when do we use these? So if someone has excessive wind drainage, they have a history of MRSA or VRE, those MDROs we talked about, C. diff, if they've been exposed to norovirus, if they have any suspicious infectious diarrhea, head lice, body lice, scabies. Additionally, respiratory syncytial virus or RSV would get contact precautions, and they would also get a mask from droplet precautions because of the way that RSV is transmitted. So the goal here is to put a barrier between you and the infectious agent. And the intent is to protect yourself and other patients. Um, so we want to make sure that we're protecting like our clothing, because if you take care of a patient without protecting your clothing, and then you go to see the next patient, you could potentially transmit infection from your clothes to that next patient. So on arrival, you might ask about that history of multi-drug resistant organisms. You might ask about history of C. diff or current C. diff infection. Do they have any infestation or wounds? And then you would add any necessary PPE based on the symptoms. So eye protections or face shields, fluid-resistant gowns or coveralls to protect the legs, gloves, and always maintain the standard precautions. And then hand hygiene at all the appropriate moments. For transport, consider using an impermeable sheet between the patient and surfaces when drainage or incontinence are a concern. Droplet precautions, when to use them. So this is a little bit, of a specific list. You might not know that the patient has these particular ailments: Neisseria meningitidis, mumps, mycoplasma, streptococcal, other causes of pneumonia, parvovirus, pertussis, pneumonic plague, rhinovirus, rubella, seasonal influenza, streptococcal pharyngitis. Again, you likely won't know what their true diagnosis is. The best thing to think of is if they have a cough, they should be in droplet precautions. So this adds additional respiratory protection to prevent inhalation of large droplet particles. So on arrival, have some awareness about any outbreaks in the community. Ask about symptoms and then add that necessary PPE based on the history. So that PPE would be a surgical mask, gloves, eye protection, and face shield. And you want to apply a surgical mask to the patient if they can tolerate it, and make sure to encourage good cough etiquette with them. And then minimize the use of nebulizers and airway interventions that stimulate coughing if possible, just to minimize the amount of droplet particles that are going into the air. And then if your ambulance system allows changes in ventilation, you could adjust those ventilations to help circulate the air through. Airborne precautions, when to use them. So again, this is kind of having some awareness of what's going on in the community, but measles, mpox, TB, whether it's suspected or confirmed, varicella or chickenpox. The goal here is to add additional respiratory precautions to protect against those smaller inhaled particles. And those smaller particles are much lighter weight, so they can remain suspended in the air for longer periods of time. So you have to think about that when it comes to if you have to close an airspace for a little while. If you had someone with measles, there's a certain amount of time that a space would need to be closed, like your ambulance. After that, because measles can remain suspended in the air for so long. So on arrival, you would want to have awareness of outbreaks, ask about symptoms, add any necessary PPE based on that history, and then making sure we're asking about exposures to TB, measles, varicella, and then add that PPE as needed. So for this, you would need a NIOSH approved N95 respirator, which you have been fit tested for, or a PAPR. You would also need gloves and a gown if needed. And then perform hand hygiene at appropriate moments. So remember that those aerosol generating procedures, like nebulizers, can generate those even more small particles to be suspended in the air. So it's important that you're wearing that N95 or PAPR. All right, IP911, masking common mistakes. So masking can be a struggle with warmer temperatures and being in patients' homes. This can be a struggle for EMS and fire, but it's important nonetheless. So some common mistakes are incorrectly wearing the mask. If it's not covering your face appropriately, you're wearing it incorrectly, it's not doing its job. How you put the mask on and take it off matters, especially when it comes to the order of PPE. So incorrectly donning or doffing the mask, touching the mask while you're wearing it, talking with the mask pulled down, and then inappropriate hand hygiene. So that's going to come in with whether or not you accidentally touch the mask, whether or not you, when you take the mask off, you need to perform hand hygiene after that. So those are all some common mistakes that we see. So this is a really great visual to show you why masks and face shields are particularly protective when there's a chance for coughs or sneezes. So in this video, you'll notice that the healthcare provider is collecting like a nasal specimen, but think about it just as a cough or a sneeze, because that can happen anytime, regardless of you collecting a specimen or not, which you would not likely be doing. But coughs and sneeze happen regardless. So this video is going to show you why it's so important to have the appropriate PPE. You can see all the areas that are glowing are areas where that overspray, those droplets have come out from the cough or sneeze that the patient might have. All right, so depending on the policy and procedure for your agency, you've either been fitted for an N95 respirator or your agency provides PAPRs or CAPRs. So while fit testing is done annually, a seal check should be done every time you put on an N95 respirator to ensure that it is on appropriately. So this video does an excellent job of showing that process, so I'm going to play the video now.
When you must wear a respirator to protect yourself against airborne contaminants in your workplace, it is very important to follow proper procedures for putting it on and taking it off. The process of putting on and taking off your respirator is also referred to as donning and doffing. Respirator manufacturers supply instructions on how to properly don and doff, put on and take off each respirator they produce. The manufacturer also supplies instructions on how to properly conduct a user seal check. A user seal check is a way to verify that the respirator has been properly positioned on your face to assure a proper seal. Sometimes workers confuse the term user seal check with the term fit test, which is different. A user seal check is not a substitute for a fit test, which is a more involved process that uses a test agent or instrument to verify the respirator's fit. A fit test must be performed before you wear a respirator for the first time and at least annually thereafter. A user seal check must be performed each time you put on a respirator to check that it has been donned correctly. Remember, always follow the respirator manufacturer's instructions for the specific respirator model that you are using. Here are some general instructions for properly donning and doffing and properly conducting a user seal check for the two most common types of respirators. Let's begin with general instructions for a disposable filtering facepiece respirator, which is often referred to as an N95 or a dust mask. Inspect the respirator, including the straps, for tears or damage. If you find any damage to the respirator, replace it. If your respirator comes out of its original container folded flat, open the folds fully, following the manufacturer's instructions. Using one hand, place the respirator on your face with the nose piece at your fingertips, allowing the headbands to hang freely. The nose piece should span and cover the bridge of your nose, and the respirator should cup your chin. Pull the top strap over your head, resting it high at the back of your head. Pull the bottom strap over your head and position it around your neck and below your ears. Be sure not to crisscross the straps. Make sure that your mouth and nose are covered by the respirator. If the nose piece has a metal nose piece or strip, use both hands to mold the nose strip to conform to the shape of your nose by pushing inward while moving your fingertips down along both sides of the nose piece. Next, conduct a user seal check. It's essential to follow the manufacturer's user seal check instructions because the manufacturer knows the best method for checking their respirator. Generally speaking, the manufacturer's instructions are based on covering the surface of the respirator, usually with your hands, so that air is prevented from passing through the filtering facepiece. A positive pressure seal check is performed by gently exhaling to see if the facepiece bulges slightly. For a negative pressure seal check, take a quick deep breath to see if the facepiece collapses slightly. During either test, if air leaks out between your face and the respirator's face seal, the respirator may not fit your face properly. One way that you can identify leakage is if you feel air blowing through the seal onto your face or eyes. If you feel leakage, readjust the fit of your respirator and check the seal again. If you cannot achieve a proper seal, you are not protected and should not enter a hazardous area. See your supervisor to determine what the problem may be. When you're finished wearing the respirator, carefully remove it without touching the exterior, because the exterior may be contaminated. Discard your respirator according to your company's procedures.
All right. So some other things that can impact how your N95 respirator fits can be facial hair. So this can impact the seal of the respirator as well. So you can see this infographic here from the CDC to see if there's a risk of seal disruption based on the facial hair that you have. So it's important for anyone who's decided to grow facial hair who didn't previously have it, has decided to change their facial hair. And this is also something to consider when that trend rolls around with No Shave November. So anytime facial hair changes, the seal of your mask can change too, which could leave you unprotected. So remember this, refer to this, and then consider what changes might need to be made. IP 911, eye protection. So nearly 2,000 eye injuries occur every day in the United States per the CDC, and eye protection recommended anytime there is a risk of acquiring an infectious disease via ocular exposure. So that's going to include splashes and respiratory droplets. So some systemic infections which can occur from ocular exposure would be bloodborne viruses like hepatitis B, hepatitis C, and HIV. Herpes viruses, rhinoviruses. So all of those can be prevented if you wear eye protection. Now, perform hand hygiene after removing eye protection. That is also very important to remember. IP 911 obstetrics. So obviously delivering a baby is not ideal in a setting which is not set up for delivery, but it happens, and EMS professionals have to be prepared to protect themselves, the mother, and the newborn. So we need to assess the situation. So if delivering the baby, these are the recommendations for personal protective equipment from the American College of Obstetricians and Gynecologists, or ACOG. So standard precautions apply here. We want to assess the situation. And then the PPE that you should be wearing would be gloves, and sterile gloves are recommended here. Gown, mask, and eye protection. And then you might also consider that impermeable drape, that barrier to prevent any type of bodily fluids from contaminating the area around them. And then be aware of any bloodborne pathogen exposures. If there's any punctured gloves, splashes, or needle stick injuries, those all need to be reported and addressed. So PPE donning and doffing, like I said, the order of which you put PPE on and take it off, it matters. And it's crucial to follow the appropriate steps to avoid contaminating yourself or the areas around you. So the ASPR Tracy EMS Infectious Disease Playbook does a fantastic job of listing the steps for donning and doffing based on the level of precaution. So refer to that guide or the CDC for further instructions. But here I'm really just going to cover some tips to avoid common mistakes we see when donning and doffing PPE. So one thing is to make sure you're performing hand hygiene before and after donning and doffing of PPE. So when you're donning, ensure that the gown is secure in the back. So we often will see gowns put on and people might not secure them in the back, and that can leave your back exposed. That can leave areas where the gown is falling down and cause exposure. And then never put gloved hands on or near the face because then you could be contaminating your face. For doffing or removal of PPE, remember the type of gown that you have also matters how you take it off. So if you have a pop type gown, then the pop gowns are removed with the gloves on. And then you take the gloves off as you're removing the gown. It kind of folds into the gown. If you have a tie gown that has to be untied before you can get it off, then you need to take your gloves off first and then remove the tie gown. And it's always, you always want to remove your mask after your gown removal and make sure that you're properly disposing of PPE. Cleaning versus disinfection. So cleaning is the manual removal of visible soilage. And so disinfection is complete or nearly all removal of pathogen life on non-living objects. And the type of disinfection, there are different types, but EMS and fire will typically, your equipment typically falls in the low-level disinfection category. So what is what is the difference between cleaning and disinfection? Well, we just covered that, but think about cleaning and disinfection in the steps that we do it. So it can be done in 2 steps, just like we said, or there are products that can do both steps in one. So the use of these products will depend on the surface and the situation. So how do these techniques apply in the field? So let's talk about ambulance and equipment decontamination. So this is from OSHA, and not everyone is an OSHA state, but it is still important to know, and it's a good definition for decontamination. So per OSHA, decontamination means the use of physical or chemical means to remove, inactivate, or destroy bloodborne pathogens on a surface or item to the point where they are no longer capable of transmitting infectious particles, and the surface or item is rendered safe for handling, use, or disposal. So some things to remember with ambulance and equipment decontamination, we want to make sure we are following the manufacturer's instructions for use, or the MIFUs as they are commonly called. So that is important for both the disinfectant you're using and the equipment you're cleaning. So making sure that you are using the appropriate disinfectant appropriately and making sure that the equipment you're cleaning, that you're following the instructions of how that manufacturer wanted the item to be disinfected. So visibly soiled surfaces and items should be cleaned first and then disinfected using an EPA-approved disinfectant. The choice of your disinfectant will depend on the situation, equipment, and timing. And then those different types of those levels of disinfection that I was talking about include sterilization, disinfection, and cleaning. Now, again, most of the items and equipment and surfaces that you will come into contact with will need low-level disinfection. So understanding the disinfectant your agency uses is essential to ensure that you are using it correctly for safety and effectiveness. And this is a really nice infographic from Project First Line on how to read a disinfectant label. So you can see here that the label will have the active ingredients. It will have that EPA registration number. The instructions for use, that is where it's so important. So where should the disinfectant be used? What germs does the disinfectant kill? What types of surfaces can the disinfectant be used on? And how do I properly use the disinfectant? Contact time, that is another big one. This is so important. How long does the surface have to stay wet with the disinfectant to kill germs? So oftentimes people think they can just clean a surface and one quick wipe will do the job. That is not the case. With disinfectants, there is a contact time. You can see this one in particular is 10 minutes. 10 minutes that this surface has to remain wet in order for it to effectively kill these pathogens. So often disinfectants have various contact times. So it's important if you use more than one disinfectant in your agency that you look at the contact and know the contact time for each of these. Some of them are a minute, some are 2, some are 4, some are up to 10. So it's super important to know which one. The label also has signal words like caution, warning, danger, precautionary statements like what type of PPE do I need to use this safely, first aid, should you get it in your eyes, mouth, skin, if you breathe it in, and then how to store and dispose of the disinfectant. So there are many different types of disinfectants. You have chemical disinfectants, so those can be your alcohols, your chlorine and chlorine compounds, hydrogen peroxide, iodophores, quaternary compound, ammonias, and you can also have these miscellaneous inactivating agents. So you can have germicides, metals, which act as microbicides. You can have ultraviolet radiation. There's pasteurization, flushing, and washer disinfectors. But knowing what you're using the type or method for is the key to finding the most effective one. So there are a few common types you might see in your agencies, but for specific needs, you can always refer to the EPA. So the EPA has various disinfectant lists. They have A, B, G, H, J, K, L, M, N, O, P, Q, and S, and each list is specific to the disinfectants effective against certain pathogens. So for example, the EPA list N is related to COVID-19, and the list Q is for viral emerging pathogens. So it is important to note that bleach really is an effective disinfectant that kills the majority of pathogens, including spores, which are harder to kill. But the quaternary ammonium compounds are effective against many pathogens, just not spores. But the bottom line is that there's many different types, each having their own advantages and disadvantages. But it is just important to know what your agency uses and how to use it. So this is just a glance at the EPA list for registered antimicrobial products that effectively kill C. diff spores. So this is list K, so not unlike the lists that we were just talking about. This is just an example of one. So you can see it's a great example of the registration number, the active ingredients, the name, the contact time, the surface type, and then the sites where it can be used. Equipment. So thinking through some of the equipment you encounter daily, what method do you use to clean and or disinfect these items? And are you following the manufacturer's instructions for use? And are you using the appropriate disinfectant? So some items to think about, the semi-critical items, delicate equipment, any patient transport equipment, various medical kits, emergency apparatuses, miscellaneous equipment. What about the station and the living quarters? And then also, what if you have soiled or contaminated uniforms or gear? What about boots, shoes, or footwear? So it's super important that we follow your agency's policy and procedure for these items on how to either have them cleaned and disinfected or to have them replaced. High touch surfaces. So cleaning and disinfection are important for all areas, but there are some surfaces considered to be high touch when you should ensure that your disinfectant, when you should ensure that you disinfect them at regular intervals, and then of course when soiled or contaminated. So this study was by Verona Barquin et al., and it looked at the detection and characterization of surface microbial contamination in emergency ambulances. And this was a cross-sectional study from Spain during July of 2012, looking at 10 basic life support ambulances. And while this was a small study, it was telling for microbial growth. So microbial growth was found in 73% of ambulance samples. And the areas that had the highest bacterial load included the unit steering wheel circumference, the inner door handle of the driver's cabin, and the stretcher's left handle. So there were various types of pathogens identified in these different samples. Some other high-touch surfaces to consider would be monitors, blood pressure cuffs, handles, equipment bags, seat belts, control buttons, light switches, and oxygen flow meters. So those are areas that we really need to focus on when we're doing our cleaning and disinfection. And these pictures are courtesy of Green Township Fire and EMS. And so you can see that some of these photos include some common high-touch items that would need to be cleaned and disinfected regularly. So monitors, phones, tablets and radios, steering wheels, and control panels. All things that we use on a run, those are things that have the probability to be high touch and need effective cleaning and disinfection. These pictures are also courtesy of Green Township Fire and EMS. So you don't want to forget the high touch areas back at the station. So you think about the things when you're on the run and you're in the ambulance, but it's also important to keep everyone safe and healthy at the station, in the living quarters, and cleaning and disinfection practices can help break that chain of infection there too. So door keypads, handles, computer keyboards, and mouse, refrigerator handles, and remotes. Those are all areas where you would want to continue your cleaning and disinfection practices. And routine and scheduled cleaning and disinfection. So this is done after any possible contamination, contact with patients, and then per the agency's policy and procedure as well. So it is so important to remember we are so lucky to have advanced technology today and have these enhanced no-touch cleaning methods, and they sound so great. But it is so important to remember that these exist, but they do not replace cleaning. So some of these options for no touch would be like gases, dual systems, aerosols. These are chemical enhanced no touch. There's also UV light that we use for disinfection. But it's just so important to remember that while these are options and they're a nice addition, another layer to remove more pathogens, but they don't replace cleaning. So that's just something to remember when you're looking at your process. Onto our next IP911, glucometers. So glucometers continue to be a piece of equipment that we focus on for cleaning and disinfection, and manufacturers' instructions for use must be followed. And remember that those finger stick devices are for one person only. So there's another study by Miller et al., and it was published in the American Journal of Infection Control in 2020. And they found an area of opportunity where we need to be changing our gloves between finger stick and disinfection of the device. So after the test is complete, remove gloves, perform hand hygiene, put on new gloves, and then clean and disinfect the glucometer. And this ensures that your contaminated gloves and hands are not recontaminating what you're actively working to disinfect. And so now let's talk about safe injection practices. They are imperative to keeping you and the patient safe, and these are just some of the basic safe injection practices. So aseptic technique when preparing and administering medications, remember that it's one needle, one syringe, one time for every patient. And use a different syringe and needle when you're entering a medication vial, bag, or bottle. And single-use medications are never for more than one patient. We want to make sure that we're limiting multi-dose vials when we can and dedicate them to a single patient when possible. But if it's a true multi-dose vial, make sure we're keeping it in a clean med prep area away from actual patient care. But also be aware of how you hold the vials when you're cleaning and disinfecting the tops. So you want to make sure that you're not recontaminating that rubber septum that you just disinfected prior to accessing that vial. Again, your state might not be an OSHA state, or maybe it is, and these guidelines are, what you follow, but they're still very helpful in following safe injection practices to prevent needle stick injuries. So contaminated needles and other contaminated sharps should not be bent, recapped, or removed, except as noted below. Any shearing or breaking of contaminated needles should not be done. Contaminated needles and other contaminated sharps should not be bent, recapped, or removed unless the employer can demonstrate that no alternative is feasible and that such action is required by specific medical or dental procedures. Bending, recapping, or needle removal must be accomplished through the use of a mechanical device or one-handed technique. And then immediately or as soon as possible after use, that contaminated sharp must be placed in an appropriate container. The container must be puncture resistant, labeled, and color coded, needs to be leak proof. So these are all things to remember, regardless of whether you're an OSHA state or not. These are things that are going to prevent you from getting a needle stick injury. Vascular access. So there's definitely a difference between central access and peripheral access. You might see central lines, PICC lines, things that, midlines that patients have. You are more likely putting in peripheral IVs or interosseous lines or IOs. While these are all different lines, I put this picture here for you to remember that no matter where the line goes in, it's all going to one place. It's going into their bloodstream, and that bloodstream is going to their heart. So if you do not clean or disinfect these needleless access devices, these caps, prior to using this for access, you could effectively be pushing pathogens into the bloodstream. So two key things to remember when it comes to vascular access, regardless of the type of access you have or you're putting in, skin prep is vital to both types of access, and disinfection of that needleless access device. So these little caps on the end of the line, those are going to prevent pathogens from entering the bloodstream, whether you're accessing or you're putting in a line. And you can see here the risk of contamination when you access a needleless access device without disinfecting it first. So when the dedicated internal pathway is accessed and opened, pathogens could then be pushed. These green things are the pathogens. The pathogens could then be pushed into the needleless access device when this dedicated internal pathway is opened up, could push them in there. And that goes straight to their bloodstream, straight to their heart, and that can cause a bloodstream infection. So make sure we're disinfecting this with your agency's approved antiseptic pad, like it's likely alcohol or a CHG alcohol combination. Make sure you're doing this effectively before every access, even between medications and flushes. So that means scrubbing this NAD, giving your flush, scrubbing it again, providing your medications, scrubbing it again with different antiseptic pads, a different alcohol pad every time, and then then doing your last flush. So it's between every access. And also on this note, sterile procedures could be required at times. So like an IO insertion, it's important to find a safe place for your sterile field. So when you're assessing an area, you want to avoid areas that are likely to be contaminated. So avoid the stretcher or cot, avoid equipment bags that kind of go in and out of patients' houses. Avoid any items you would consider just inherently contaminated that might lead to a high risk contamination of your sterile field. Now, exposures unfortunately do happen, so your agency should have an occupational exposure plan in place. So the occupational exposure plan can be on file, and it can help prevent exposures, as well as outline steps if and when an exposure occurs. And it can also explain the definition of an exposure. So I put this here. This is this is a list of potentially life-threatening exposures. So we know that we could get exposed, be exposed to many different types of infectious disease, but this list are the high concern, the potentially life-threatening exposures. And you'll notice that some of the things on this list are vaccine preventable. Some of them not, but some of them are, which is why there are vaccine requirements prior to starting a job in healthcare or fire and EMS. So some potentially life-threatening exposures would be anthrax, hepatitis B, hepatitis C, human immunodeficiency virus or HIV, rabies, vaccinemia, viral hemorrhagic fevers, measles, tuberculosis, varicella, diphtheria, novel influenza A, meningococcal disease, mumps, pertussis, plague, rubella, and SARS-CoV. So again, some of these are vaccine preventable: hepatitis B, measles, varicella, diphtheria, mumps, pertussis. All these things are, not everything on this list is vaccine preventable, but this is why we have vaccine requirements for certain jobs, because it is a potentially life-threatening exposure. So occupational exposures and post-exposure response needs. So this is from the CDC. It does speak specifically to HIV, but I do think that it is something that we can consider for organizations making a difference regardless of the exposure. But occupational exposure is considered an urgent medical concern and should be managed immediately after possible exposure. The sooner the better. Every hour counts. So again, this speaks specifically to HIV. Review the CDC's guideline for the management of occupational HIV exposures. When personnel are exposed, the CDC recommends immediate treatment with PEP to prevent infection. So we want to train personnel in infection control procedures, remind personnel to report occupational exposures immediately after they occur, develop and distribute written policies for the management of occupational exposures, promote the use of safety devices to prevent sharps injuries, and report all cases of occupational HIV exposure to the State Health Department HIV surveillance staff and the CDC coordinator at this number. So this is something a really big thing for the organization and the DICO officer as well. So Ryan White. So more than likely you've heard of the Ryan White Act, but do you know who Ryan White was? Ryan was a 13-year-old hemophiliac who contracted AIDS from a blood transfusion in 1984. Unfortunately, he died in April of 1990, but he and his mother fought for public education about AIDS, and they rallied for his return to school before his death. But when he returned to school, people just didn't understand how HIV and AIDS were transmitted. So the way he was treated just it was not great. He was isolated. It was just not a great time for him. So they needed education on how to understand the transmission of HIV and AIDS, and also needed funding to help reduce the spread and improve outcomes for people with HIV. So fortunately, in August of 1990, the Ryan White Comprehensive AIDS Resources Emergency Care Act passed. So this was a 5 funded parts of the act, and the goal was to reduce the spread of HIV and improve outcomes. And this is an act that is still in place in legislation today. For vaccination, what vaccines should you have before starting as an EMS or fire professional? So that would be hepatitis B, influenza annually, MMR, and varicella unless you have verified immunity. And these are just some resources for fire and EMS providers to help guide you through infection prevention and control practices specific to your profession, which, like I said, resources can be limited on. But the EMS infectious disease playbook that I refer to many times, the Guide to Infection Prevention and Emergency Medicine is also good from APIC. And then, of course, you've got your bloodborne pathogens standard from OSHA. Some key takeaways: standard precautions always apply. Transmission-based precautions are added based on the symptoms and the situation. Hand hygiene can be performed multiple times throughout the run, and remember that gloves are not a substitute for hand hygiene. Cleaning and disinfection is one way to break the chain of infection. Safe injection practices can keep you and the patient safe, and the DICO personnel acts as the agency's infection preventionist. And these are the references I used to create this presentation. And for any future information, or if you want to stay informed with us, you can follow us on social media. You can also visit our website and reach out to us if you have any further questions at kentuckyiptraining.org. Thank you so much for listening to this presentation.